enhance it. And I think this is important when understanding and measuring what PA pressure is on the in the circulation, be it at rest or during exertion, is important. So we always do that. And it is cheap, so you don't have to use the newer ultrasound agents to be able to do that. So I think that is suggested. Now these have in a gas self, so part of the development process of the newer ultrasound contrast agents have been the manufacturer shell itself and what kind of gas is inside that shell. And usually they're inert, either air. The problem with air, it can in and out, so you'll have diffusion. If with a high molecular weight gas, just like we're used with the second generation, third generation ultrasound agents, with a thicker shell, you may not have much of that, and therefore you of these tiny little micro bubbles, and then you'll be able, because of their size, to cross the pulmonary circulation to the left side. The ones in yellow, Optison, Definity, and Lumason, are the three agents that are available to us nowadays in the United States. There are other different parts of the world, Imagent and Levovist. There are. Take a look at the size. The size is very small. That's part of the reason they cross the pulmonary circulation, usually less than 3 microns. Albumin is the shell as opposed to the lipid monolayer, and you could see what the gas is per fluorine or sulfur hexafluoride. Few things as to or understanding or optimization of the images with contrast. Now, people, they don't like to show such cases, right? I mean, this is a fully uninterpretable study from the apical window, right? So, and you use contrast and it becomes very interpretable. You can measure the size of the ventricle, you know what regional function is, what global function is like, and I think these are very important. The question is, how do you enhance such? What are the things that you really need to know about the various issues? One is that these tiny microbubbles, irrespective of the agent they're using, can reflect a lot of ultrasound, as you can see. So, if you inject a fully concentrated and a rapid injection, you're going to have so much contrast coming in that at some point in time it may reflect all the ultrasound. So all what you see is a reflection at the surface of where that bolus is. So for the sonographer, the nurse that is administering, and as well as the interpreter, you need to know what attenuation was. Too much contrast. So let's take a look at this injection. This is the right ventricle, where the right ventricle is. Most often, you're not going to see much on the right ventricle. And the reason for it is the initial bolus will have a lot of concentration. So what you see is the ultrasound beam is coming in this direction. So you'll see the initial surface and everything behind it here, but usually waiting is the best way. And then you could see it throughout, right? So it depends on the situation at times, from the parasternal lung or wherever it is. If you have too much contrast, it's going to shadow behind it. So these are the pros and cons of contrast echocardiography. Where I think it's important to know the setting on your ultrasound machine. And we talked in the first such lecture on the basics of ultrasound imaging, is that the mechanical index is actually the power that is sent towards the image, object. So the mechanical index is peak negative pressure, meaning the height of this wave by the square root of the frequency. So the mechanical index is higher, right? The bigger the magnitude of this wave. And why is it important, particularly for contrast echocardiography? It's important because, remember, the frequency is very high. So you're talking about thousands and millions of these waves occurring. But during the negative portion, right, these bubbles, which stretch, compress, and stretch, will be overstretched and will burst, basically. I mean, that's how you destroy them. So if you have a regular mechanical index that is given and your imaging contrast without altering any of your settings, you will destroy quite a bit if you use the regular imaging, okay? So what are we talking about? Mechanical index, we talked about it in the first lecture. A mechanical index greater than 1, that's the unit, if you will, is very high. So you're going to destroy quite a bit of these microbubbles. If you come down on the mechanical index, meaning less power sent, you won't destroy as much. Some of these will resonate, and you'll have, very nice. So nowadays, if you want really to image continuously almost these microbubbles, your mechanical index will be less than 0.3, at times 0.2, and at times 0.1. Now, many of these ultrasound machines will have presets for contrast itself. So you set contrast, whatever it is, and the preset is to lower the mechanical index to start with. Now you may not be able to see as well the myocardium or the other structures, but you will enhance it for contrast imaging because these microbubbles will resonate and will emit this. This is the effect of intensity and duration of the mechanical index. So what we're going to do here, this is MI is 1.5, which now I'm going to play it and you will see what happens. It almost looks like a hurricane, meaning quite a bit of the contrast that came in is being destroyed, and that's why you start seeing hurricane. You know you're not overdoing it because you don't have the shadow behind it, right? So you could say maybe, maybe it's I have very little contrast, but actually you have very little contrast because you are destroying it, okay? Notice in that area, once I start bringing down the mechanical index to 0.3, 0.2, that you will have uniformity of the contrast. You won't see this hurricane effect, and you'll optimize, right? So let's play it. Look at it. See a little hurricane goes to the tip of the heart. I don't see much contrast. I'm going to start, here you go, decreasing it, wait, and watch. The whole heart is filled. The contrast intensity is much higher. I'm going back to 1.5. This is a loop, basically. You don't see much close to the apex. It's being destroyed. Gradually coming down, and within just few seconds, you're replenishing. So again, to tell you that this is very important to pay attention to the mechanical index, or at least have the setting optimized for contrast imaging. In the first lecture on the basics, we talked about, harmonic imaging, second harmonic imaging. So ultrasound from your transducer, you're sending a certain fundamental frequency, and that could be whatever it is, 3 megahertz, 4, 5, whatever it is, but usually, let's say 3.5 or 5. You hit a structure, and that structure will reflect back the same ultrasound frequency, the fundamental one, but also once you hit that certain structure, particularly the microbubbles, they will resonate. And they will emit, in addition to the fundamental frequency, a multiple of are very deformable, and they will emit quite a bit of that second frequency. So always less than the fundamental, but if you emphasize it of the tissue, you're going to see much more contrast. Again, part of optimization. So the first part of optimization, make sure that the mechanical index is not too high. The second one is look at second harmonic, okay? So this is fundamental versus harmonic imaging. There you go. So this is a 3.5. That's the fundamental frequency, okay? And before even I play the video, this is actually contrast within this heart from the fourth chamber. I barely can discern heart from the fourth chamber. I barely can discern from the cavity that has all the contrast. Okay? Okay? So within turning 3.5 to H, which is harmonic 3.5, notice what the difference looks like on the image. It will emphasize the myocardium. Watch. uninterpretable images in the ICUs, stress echocardiography, not per se, but it's endocardial border definition. Doppler signal enhancement on the left side, on the right side too, but on the right side, obviously, agitated saline is the cheapest one and most available. And definition of structural abnormalities. If you see better, obviously you can define it, whether I have a thrombus, I have a pseudoaneurysm, where the connection is, that can really help you. No question about it. And from an ACC, ASA point of view, appropriate indication, obviously, if I don't see two or more early days, we've deputized to make that determination, as opposed to early on the physician or the fellow trying to see it yes or no. I think if somebody is starting anew, obviously you have to give feedback to the sonographers as to appropriate or inappropriate indication. Well, take a look at this. Obviously, you can't tell too much. And if I use contrast, I can tell a lot, right? Ventricular function is good. And nowadays, truly, if you are in a good laboratory, even an outpatient laboratory who is just a private practitioner in an outpatient laboratory, you should be able to do that. Nowadays, it is inappropriate. It is inappropriate to not interpret almost anything, particularly use contrast. It is inappropriate. Because from a reimbursement point of view, it's the same reimbursement if you've done it yes or no. But just imagine if you can't interpret anything. Now, there are some situations where you can't interpret despite use of contrast. But I think it would be inappropriate nowadays for you to be able to do that and not use contrast for those indications. Now, for this case here, you could tell even without contrast that the ventricular function is very depressed. No question about it. EF probably somewhere in the 20s, severely depressed, some mild regurgitation. You could say to yourself, do I really need contrast, yes or no? I think you do, because whenever you have a ventricle like this, you may have issues. And this is one issue that you can discover. That's the same patient, right? You have a thrombus at the apex, it changes management, it changes prognosis, outcomes, and everything else. So you have to know, particularly when the ventricle is quite depressed. Two of them are older, but I'll keep it because you can tell the ventricle is hyperdynamic. What can you tell about the apex? Not sure, right? Use contrast, changes everything, right? So this is a hypertrophic cardiomyopathy with actually almost a little entrapment of the apex itself. The ventricular function is hyperdynamic with a very thick set. And this, I haven't seen another case of it. I was involved directly in it. Patient came in, patient of our Dr. Kleiman, and I said, this looks like normal to me. I didn't see anything. And I gave you the best pictures. All the others are, decent. He said, well, the EKG is very abnormal. And this was in the early days of contrast. I said, well, why don't we bring the patient back and see what the situation is? Because, yes, your eye will extrapolate, right? I don't see every little, endocardial border. And indeed, it is very abnormal, right? Because the abnormality is a very unusual situation, right? It is localized in the mid-lateral wall, mid-anterolateral wall. You could see it right here. You could see it right there. Because our eye basically closed this gap, and this is where the abnormality was. And here, closed the gap, and this is where the abnormality was, right? So most of the time you'll be correct, but in certain situations you may not be as correct. I mean, that's the situation here. This is a patient, actually, this was had chest pain, and this is the EKG. So obviously the question is it a weak event? And here you go, that's your echocardiogram. maybe some wall motion abnormality in the apex. I infer that the wall motion is decent because the epicardium is coming in. I cannot tell you about the endocardium per se. And this is what you get, Doctora. It's an apical HCM with a typical ACE of deep symmetrical, but there still could be ischemic, right? We don't have previous EKGs to know what the situation is. How about this patient? This patient, I think for the uninitiated here, has an abnormality in the inferior wall, no question about it. Can't tell here, can't tell there, but this is where the abnormality is. And this is contrast, interestingly enough. There is an abnormality in the apex, and on top of that, there's a thrombus in the apex. Interesting, isn't it? So, message is, I'd like to know as much as I know, right? And the others I extrapolate. At times, you know, I'll be all right, but there are situations where it will change significantly what the situation is. How about this case? What do you think? What's the situation here? Probably, it could be most likely a hypertroph here. You're really not sure. But I'll tell you, without contrast, one thing that is definitely abnormal, what is definitely abnormal is usually in a heart, yes, you have endocardial motion, right? But usually you have epicardial motion that comes towards the mid of the cavity. If you don't have the epicardial movement in, the differential is either I have an aortic segment or I have no place to go. Okay? So here, from this area of the septum upward, and even here, there isn't much motion of the epicardium coming in. So, is there a lot of muscle here that is cavity obliteration? Likely, yes. There is a suspicion, and this is where you would use contrast, and you could see actually some of the arterioles come obliterate, you know, hypertroph in this situation. Okay. So, having gone through the basics of contrast, in this image, there are two situations we talked about, and can you tell them to me?
Top right is there's a lot of contrast.
Top right, a lot of contrast. So we have a lot of contrast. Somebody has, I mean, nowadays we dilute it, although in the package insert tells you, doesn't tell you anything about dilution, but you will avoid such a situation, or you inject very slowly and dilute it. So you have attenuation, you have too much contrast. So that's one. Bottom middle.
Sonographer is trying to destroy all the bubbles.
Trying to destroy all the bubbles. You got it. High mechanical index. I cannot tell if I can see it here. Same situation there. Okay, and this is an enhancement of an aortic stenosis jet. This is your AS before. You wonder how high it is. Be careful about enhancing Doppler jets. You will at times overestimate or increase what the velocity is. If you're trying to push for somebody to get a TAVR procedure or otherwise, hold your horses down a little bit, right? So after you inject the contrast, if you can't, just wait for it to diffuse a bit so you have less concentration and less over blooming of this situation. Same thing with TR jets. Again, early on, you may have, so wait for it to come down a little bit so that you don't overestimate, the situation. The impact is most likely is in this situation. I haven't changed this slide for years. Most patients, have, unless you're dealing with a lot of COPD or special populations, most often you're not going to use contrast in a regular resting echocardiogram, more in the inpatients, more instrumented patients, and for stress echo, we'll talk about that, okay? And this is a very early study here from us, comparing harmonic, contrast, etc., similar to TEE. These are in the ICU situations, right? So in the ICU situation where I can't, I can't interpret much ventricular function, using contrast is very beneficial, right? You will. In the past, what contrast was at its, and nowadays it's a moot point to ask even that question, but early on, you can get your evaluation of ejection fraction, ventricular volumes, etc. How about stress echo? Stress echo, as we talked about, it is not a pure indication for stress echocardiography. And, there's a case of a normal versus somebody with a dobutamine echo, etc. And current utilization, I hope it's not zero, but for many years it has been zero. Not too good to look at. Because there are some laboratories who use it all the time, and I don't think you should. There are laboratories who don't use it at all, I don't think you should. And the ones that benefit the most, obviously, where you see all the segments at baseline as well as during stress. And are they effective? And yes, indeed, they're effective. And this is Juan Carlos Plano now actually is just 2 dobutamine section. You're not going to be able to do this often, and the gold standard was cardiac. That's what you'd expect also, is that if you had no contrast versus contrast, segment visualized more than 90%. And the beauty of it is also notice that although 72% were adequate without contrast, it goes down. Whenever you have stress, your imaging goes down, as opposed to staying the same or up, probably the same, whenever your time is. This is from an interpretation of the physician point of view, is make the decision before you do the stress. And be it exercise or be it the radiographer is struck pristine to start with, use contrast at rest, so you can compare contrast to contrast later on during the stress. Coronary disease compared to cardiac catheterization, no question about it. If I'm seeing all the segments by itself, I mean, if the study is pristine, there's no reason for you to use contrast. Maybe a little enhancement, more than 2 segments. I'll share a case with you here. Left side does not use contrast patients. No question. What can you say? Interpret the EKG, interpret the symptoms, but what are you gonna say? You interpret the symptoms, but what are you gonna say? Okay? Now I say suspicion for an apical abnormality. That's all what you is dilatate of ischemia that is still present. Okay? Contrast is talked about attenuation if the injection is not the best injection. When you use contrast with exercise, treadmill, okay, not exercise. I mean, that's the most challenging, is exercise treadmill if you're going to use contrast. Use it at baseline, but you have to inject contrast and guesstimate about half a minute before they lie down, because you want the contrast to circulate. And if it is too much, you're just going to have to wait a little bit. Ideally, for contrast use with stress is either pharmacological or bicycle stress, where you could use it continuously. You have time to acquire, adjust the images, etc. Here is about linear eye and interpret. See this linear? Now this one is in a hospital setting or a stress. It's already there. Use it wherever it is appropriate. And this is intuitive by itself. Dr. Kurt actually was a medical student when he was here visiting from Turkey, believe it or not. And now he's a practitioner in Turkey. I haven't seen him since he did the study. So it'll be nice to see you, Dr. Kurt, at some point in time. But it is intuitive here that the more I don't see, the more the impact, obviously, of contrast per se, right? Okay, see, these are some cases for you to take a look at, to quiz you. Is this a thrombus versus a reverberation?
What is reverberation?
Where were you in this artifact at times of ultrasound bouncing back and forth between the casing of the transducer itself and the image that you're seeing? And most often we have some of this close to the apex, right? So this is where, not sure I have a thrombus, yes, no. Usually, if you don't have contrast, if you're stranded on an island without contrast, or you don't have an IV, right? What do you do usually? You change the angulation. You go maybe a short axis towards the apex, or change, the window. So hopefully you try to decrease this. All right. What's the vote?
I mean, I would say
Thrombus, all of you.
LV function is reduced, LV is dilated.
Yeah, thrombus. I don't agree with you.
The apex is not the kinetic.
Yeah, but the apex is akinetic. So I mean, that's the problem is at times, in the right circumstances, right? So you're pushed for, okay? How about this?
This is like thrombus.
This is a thrombus. This is trabeculations versus thrombus versus whatever it is that you want to do. It is a thrombus. Thrombus plus other trabeculations, but it is a thrombus. You could see it on top. How about this one? You can't tell. It is difficult. Here we go. All right. So, utilization and safety. Used 1%. To tell you the truth, when we started educating people, it took forever. And the reason took forever is the major driver here is quality. Period. Quality. You're not going to make money. I mean, obviously, if we dangled dollar, with incentive dollars, you will see this catch up very quickly. Is the champions within an echocardiography laboratory, because yes, you will be paid for the cost of the agent, but importantly, you could see how impactful it is. It really is very impactful from a diagnosis point of view, and from a patient outcome and changing management point of view. There can be an anaphylactoid reaction, and there is a recent study looking at that. And particularly depending on the liposomal shell itself, 1 in 10,000. So therefore, the sonographer or whoever is using it, this is a drug, right? So yes, you can have an anaphylactoid reaction, and you have to is needed just in case something happens, right? The only contraindication is known hypersensitivity to the drug, so you have to ask individuals that are doing this whether they had any problem with agents before. Recent clarifications not opting to specify administration of these two agents. They are contraindicated with hypersensitivity because they have the PEG containing products, right? And this is the large study from just early on this year about many patients who understand. Bottom line is, these are safe. For the two agents who may have a little higher hypersensitivity reaction, you have to be very careful about that, and keep that in mind. And these are the Forster plots for Optison versus Lumason, Optison versus no contrast, serious side effects. And last is myocardial perfusion. This is for your information, because if you're doing some laboratory work, this is a great agent for you to take a look at myocardial blood flow. Musculature, the capillaries, idea how fast. We know how fast they are in different areas, right? 1 to 2 millimeter per second. So therefore, at the myocardial level, even though at times you may image with low mechanical index, the exposure of these contrasts, in the capillary itself is high enough to destroy them. So that's why, obviously, in regular imaging with high MI, you may not see any contrast per se. And there's intermittent imaging at the time. If you use intermittent, and you could see the difference between the left and the right. Academic careers were built on this. This is from when they were at UVA. This is from Dr. Sanjeev Kaul and Kevin Way and Jonathan Lindner, looking at how do you quantitate flow using this agent, right? So you destroy with a little flash, and then image intermittently, and the contrast will fill in, and then you look at the intensity within the myocardial wall, and then you can infer this is the speed and how much contrast there is. So you can tell the blood flow is to that particular myocardium. Hibernation, other things to know that it can be done. Now, you can use low mechanical index, we talked about, or a slow frame rate, and you have to kind of be careful about that as to when can you enhance. And this is an example of contrast that you could see it very nicely with a little flash of high mechanical index where you gradually, and you can quantitate my our patients. Somebody had a one see that there is contrast even in the apical area, which is abnormal. Now, during that period of enhancing flow, like agent, contrast was not getting into the flash, and you could see contrast come in very nicely and very you could see contrast come in very nicely and very quickly. At the same time, shows you with contrast for my notice that this lateral wall doesn't have as much contrast. And is at times it's really that if you have some attenuation from one area or another, a lot of techniques that come into play that now